think we're all set. And I want to say good evening to everyone and thank you all for joining us on this cold November evening. For those of you who still don't know me, my name is Kimberly Connell and I'm the Caregiver Services and Supports Coordinator with Onondaga County Office for Aging. You know, whenever I talk with the caregivers that I support, the topic of end of life is really rarely brought up by them. And I know because preparing for the end of life or comfort care is really difficult. But having someone support you through that process and having a team to help you care for your loved one can really, really help. And hospice is designed to help during this time specifically. The hospice team provides care that focuses on the quality of life for the people that you're caring for, who are, living with an advanced or life-limiting illness, but they also support the caregiver as well. So that's one really very unique and wonderful aspect of the hospice team. So while you might not want to think about it, preparing by learning what your options are to care for a loved one at the end of life is a really good thing. And this class can help with that. And I'm really glad that we're able to bring this to you tonight. And so tonight, on behalf of Onondaga County Office for Aging and Caregiver Services, I'm pleased to welcome you all to our Institute for Caregivers class, The Final Journey, How Hospice and Palliative Care Can Help. I worked with hospice and palliative care for many years, and I know from experience that there's a great deal of misunderstanding about both. And tonight, we're going to take a look at this really incredible program and give you all the opportunity to ask all the questions that you have or share stories or share experiences that you've had. Please feel free to break in. I know I do that many times during the class if I have a question, and Amy's perfectly fine with that. So this class tonight is going to be presented by Amy Sheltler. I'm sorry if I said that wrong. And we're thrilled to have her with us. I'm going to tell you a little bit about Amy. Amy is a hospice nurse, certified in hospice and palliative care nursing. She has dedicated over 15 years to supporting and carrying out the mission of Hospice of Central New York and Finger Lakes. And throughout her 36-year career in nursing, she has worked in the area of pediatrics, adult intensive care, and home care. But it's been as a hospice nurse that she really found her passion. As an admissions nurse and a discharge planner, there have been countless opportunities to provide compassionate end-of-life care and support to patients and families in the community. Now, Amy's current role as clinical educator also allows opportunities for her to continue to educate and support new staff, in addition to speaking on the hospice missions and services within the community, such as she's doing tonight for us. So welcome, Tammy. I know we're in good hands, and I'm going to turn over the controls to you in just a minute. I'm going to share my screen and have that. And then Amy, if you would put on your video.
Okay. There I am.
Yeah.
Okay. Okay. So,
Okay.
okay,
And
can you
hold on a moment?
Yep. Yep.
I'm in another screen. Since I'm sharing my screen, it's going to be a little awkward. I'm going to stop my video too. I don't need to be seen on here. Okay. Okay, I think we're ready, Amy.
Okay. Okay. Well, thank you for that introduction, Kimberly. And I'm really pleased to be able to talk about hospice and end of life with all of you. This is a good month to do this. November happens to be the month for National Hospice and Palliative Care. So this is a good month to do this. As Kimberly noted, that I have been a nurse for 36 years, and I have been with Hospice of Central New York for the last 15 years and have had a variety of roles and have spent many times, talking with patients and families, just thinking about hospice and what our services are. So I hope to be able to give you guys some information about us that you can take with you and be able to use it either now or in the future. So we do have a slide presentation that, that Kimberly's going to kind of navigate for me because I'm unable to do it from my end tonight, unfortunately. So some of what I'd like you to be able to take away is really to identify the differences between hospice and palliative care. And there are some similarities, but there are distinct differences as well that we'll get into. Also recognizing when hospice care may be appropriate, so that you can kind of be thinking about that when you're with people. And then understanding our services. So next slide, Kimberly.
It's trying to go. There we go.
Okay. So what is the difference between hospice care and palliative medicine? I think it helps to kind of, first of all, just kind of go back in time. And hospice, has been like really forever. The term hospice, used to mean just a place of rest. And many people think of that still. When I meet with people, they'll think, well, is it a facility? In some places it is a facility. There is a hospice. Some hospices have actual buildings. In our particular area where we serve, the vast majority are in their own home or a person's home. And we'll talk about other places as we get going here. But really, hospice is a philosophy of care. And I'm having trouble seeing the whole slide, but I do have because I'm getting blocked a little bit, Kimberly, but I'll read off of my slide here. So we're a philosophy of care, really focusing on end of comfort care, treating the whole person physically, psychologically, and spiritually, addressing all of those concerns. Modern day hospice was founded by Dr. Cicely Dame Saunders, and she was originally a nurse, then she trained as a social worker, and then finally a physician. And she really recognized that we needed to do better by taking care of the dying. And so in the 1960s, she really spearheaded that and really is what we know as modern day hospice today. And it was really the first that we had a holistic approach to treating people and treating pain on a physical, a spiritual, and emotional level, and thinking of it that way. So in 1974, the first hospice was founded. And in 1981, here in Syracuse, the Caring Coalition was formed, which eventually became Hospice of Central New York. In 2018, we did merge with the Finger Lakes Hospice, which was a smaller hospice. And so we are one now. And then just to note, in 1982 is when things really changed financially, and Medicare established a hospice benefit within it.
That was the big
So
change.
palliative care is a form of medical treatment that really focuses on managing pain, symptoms, addressing all those symptoms. They are also the goal is still quality of life. The focus is on relieving symptoms. So many similar aspects to hospice care. Did we skip over a slide or no? Yeah. So hospice is really for people with at end of life. So we have, if everything were to run its natural course, we would have really a prognosis of 6 months or less. And many people think that you need to be really on your last days of life. And we have people that maybe have many months left to live. So when we meet people and we're evaluating whether they really qualify, our docs are looking at specific things and to see if right now they qualify, but if their best guess that if things were to continue naturally, it would likely be 6 months or less. Oh, okay, excuse me. I'm in the building doing a presentation. Okay. I'm so sorry. I am at my office and I had to take that because otherwise the alarm would go off when I left the building. So
Okay.
I do apologize for that. So what we're thinking about is when somebody qualifies is really that they're at that end stage of their illness. And maybe curative treatments are no longer an option for that person, or maybe they no longer want curative treatments, or maybe the burden of it is just more than the benefit of it. So these are the types of things that we talk about people with when they're trying to decide whether this is something that they want or whether they qualify for. And really maybe what they've been going through. Maybe it's been chemo, or maybe it's been dialysis or blood transfusions for their illness. And maybe they no longer really want those because they're not benefiting them greatly. So again, palliative care is focusing on many of the same things, but it could be at any stage of their illness, which we'll talk about in the next slide. So I can have the next slide, Kimberly.
Oh, okay. You were done with palliative care. Sorry.
Yeah, I'm going to talk about a little more in depth in the next one. Yeah. So in this slide, it's kind of talking about the overlapping similarities. So with palliative care, the distinct difference is that it can really happen at any stage of the disease. So somebody maybe have just diagnosed with cancer. They want treatment, they're still getting curative treatments or palliative chemo perhaps, but they also have a palliative focus. They have the palliative care team, they're specialized nurse practitioners, physicians that have training and certification in palliative medicine, can address and approach care holistically. So they may or may not even be terminally ill. They may have COPD, they may have heart failure, they just may have chronic pain. So there's a lot of things that kind of fall into a palliative focus. And typically, people may go in and out of the hospital and they may qualify for they may be followed by the palliative care team in the hospital. And one of the benefits of having that is that the palliative care team, they know when, they are having these discussions with the patient and family along the way, and they often know when hospice might be appropriate for this person. So hospice care and the other circle.
Amy, this is Kimberly.
Yeah.
I just have a quick question for
Sure.
clarification. So when
Yes.
you say a palliative approach, what is it that you're saying? I think a lot of people are sort of confused with that term, and a palliative approach outside of the comfort care of hospice.
Right.
Means what?
Right. So it means that you can still be focusing, you're still focusing on a quality of life, improving quality of life, like you're addressing, because of the training that palliative care physicians and nurse practitioners have, they're approaching it similarly to hospice, treating the whole person, the physical symptoms, the psychosocial, they're treating the patient and family, they're addressing the whole person. And so their approach to care is different. They may be helping the person establish goals of care, so somebody that goes in and out of the hospital a lot for maybe their heart failure, they would be beneficial to get involved, because as that person is, even though they're getting aggressive treatments for their heart failure, they're helping them to think about what do they want, what's their goals, and addressing those symptoms, of course, of pain and other things that, come with that particular disease that they have. So it's the philosophy, that's what's in the circle with the common things that we have in common, is that we approach it with the patient and family in mind. We approach establishing goals of care, quality of life, but the so that really somebody that's chronically ill could qualify for palliative care. Somebody that's just frequently goes in and out of the hospital, things like that. Does that answer the question for you?
I think so. I hope so. If anybody needs further clarification, just pop your hand up. But yeah, it sounds it's very similar to the hospice model of care. The hospice took point of care, but outside of that need for a 6-month prognosis or
yes.
So it's upstream.
Well, exactly. And it's the thing with hospice care is that hospice care has palliative care within it.
Right.
So it's whereas palliative care doesn't have hospice within it. So it's very similar because it's but it's hard to really think about unless you think about specifically what a person might, like their particular illness. So chronic, you think of somebody that might have heart failure or COPD. Those are chronic conditions, and they may live very well for a long time with those conditions. But then over time, if that condition worsens and isn't being well managed, palliative care would be beneficial to them because they would help to manage those symptoms, help again to talk about, what do they want? What does that person want? Do they want to be home? Do they want to keep going back and forth to the hospital? And it helps them to start thinking about the things that maybe they haven't voiced. Maybe they're thinking about them or they don't have a place to voice that. So that's where palliative care is very helpful to that family. And then specifically with hospice care, it's really those when they're in that last phase of that illness. Okay.
Thank you so much, Amy. Now, Patricia also, I think, wants to ask a question, but she doesn't know how to raise her hand. So, Patricia, Are you able to unmute yourself, Patricia? Pat?
Can you hear me?
Yes.
Yes.
I have one question where I see where under hospice care, it's based on 6 months or less. And you said it's an educated guess by the medical providers. At the end of 6 months, if the person is still going forward, does the family have to do a new care plan, or will it just be extended without having to involve the family and, meetings or whatever?
Right. So that's a really excellent question. So, so just to clarify, with the prognosis piece, when we get a referral from anybody, which we'll talk about a little bit down in another slide, but when we get a referral, one of the things that we do have to determine, the hospice doctor has to determine whether somebody is medically appropriate. So we get as much medical information as we can at the referral. And sometimes it's very clear the person is medically appropriate. They may have cancer. For instance, cancer is very predictable. For the most part, they can determine that somebody is likely to have 6 months or less. And actually, per regulations, 2 physicians have to concur and say that they are 6 months or less. So one of them is the hospice doctor, and then the other is usually the patient's own doctor or a consulting doctor, or that's agreeing to the prognosis that it's 6 months or less and agreeing to follow for hospice. But it is always a hospice doctor that determines the actual diagnosis of why we're bringing somebody in. So the vast majority of our patients have cancer, but many don't. They fall into those other categories of either renal disease or heart failure or lung disease. And when they have those other illnesses, we have Medicare guidelines that our physician follows to determine whether they're likely at that last phase. And of course, they have the expertise and experience to know that they're likely at that phase based on different things that they're seeing or that the nurse is seeing. So once they're medically approved, they're certified. And when they're certified for 6 months. And what happens is, because we've had people that have lived and had hospice for actually the longest I've known is up to 5 years, which is obviously very rare, but we have had that happen. So what happens is after the certification period, they recertify them. And so we have like a 90-day certification, so 3 months, we recertify them if they continue to qualify, and that is on hospice to do that. So it's based on our visits that we make, our documentation. And so we have to justify and document in our records that somebody is continuing to meet the criteria for hospice. And then they're recertified after another 90 days. And then after that point, every 60 days, one of our doctors has to go out to the home to do what we call a face-to-face physical exam to determine that they are still medically qualifying, and we continue to recertify them. So they never have to, disenroll from us and re-sign up. We do the recertifications, and we can do it on our end. Now, occasionally, we do discharge people because they are medically no longer appropriate. And those are things that we talk about with the patient and family as time goes on, that they may not be qualifying any longer. Maybe they initially qualified, but then they improve, or those kinds of things. So we do a handful of discharges a month. And because we're very careful to, we can't, be fraudulent to Medicare. Medicare could, shut us down, or they could actually, ask for back pay or any of number of things. So our physicians are, we are very highly regulated, and we're very careful at that. But so I hope that answered your question, but that's basically is that it's on us, and that we do the certifications for that.
And Amy, when an individual is removed from hospice, what is the difference? Why would that happen as opposed to somebody recertifying? Are they just getting better?
So sometimes they do. So sometimes, so we could discharge for a couple of reasons. One could be that they choose just not to have us anymore, and they don't want our services, and so we discharge for that. Sometimes they move out of our service area, so we have to discharge them because they no longer are in our area that we can serve them. And then the medical reason would be because they're no longer considered terminally ill. So that might happen. It happens a lot, most typically with patients with dementia or Alzheimer's, or maybe even like a stroke. So somebody may appear, maybe they haven't been eating, or they're losing weight and things that, or they've been in and out of the hospital. And so they might, in that moment, appear to, it could go either way. They could continue to decline, or they could actually kind of stabilize and improve. Now we do take all that into consideration. So like for instance, like when we admit people with Alzheimer's, they may be with us a while because it may be a very, very slow decline. So as long as we're continuing to show that there is a decline, and it may be very small, it might be, even though like we can't weigh somebody, that we take measures to like measure around their arm, or we might even occasionally do some lab work to show and that we're continuing, that they do continue to meet the criteria, and things like that. So, but it would never come out of the blue. It wouldn't be one day we'd show up and say, you're no longer having our services. There's a process. And so we have to inform families within 48 hours. They have the right to appeal it. They can say they don't agree. And so they sign that, they get all that information to be able to call a number, the Department of Health. And so we, and then we would follow up. And so we've never lost an appeal. So we're very careful when, and we're very careful when we do discharge somebody, that we always tell them if they see a change, if there's a change tomorrow, if there's a change next week, that we can come right back out. They don't, there's not a number or limit of times that they can have hospice.
Good, okay. Well,
Okay.
well, related to that, Pat asked, I think this is just to clarify, she says, if I heard correctly, there are 3 90-day extensions and then 60 days required hospice doctor review of ongoing care. So every 60 days, there's a hospice doctor review, and there's 3 90-day extensions. Is that?
So
what
there's I misspoke then. There's 2 90-day extensions, which would get you the 3 months, and 3 months would get you to the 6-month mark. And so at the 6-month mark, it's required that it's every 60 days after that, and that that doctor has to go out and do
Okay.
it face-to-face. Yep.
Good. I think that's clear. That clarified it for me anyway. Okay.
Okay.
Thanks, Amy.
Yep.
All right. Are you ready to move on, or are we
Yep.
still here? I
Yeah,
don't
we can.
know.
Yeah, we can move to the
Okay.
next slide. Yep. Okay. So again, just to kind of reiterate, hospice includes palliative care. Palliative care, it's beneficial because it helps to support and establish goals, and help live with serious illnesses. And then as I mentioned, there you have that specialized training. There are some doctors in the community that are palliative care physicians as well. Okay. So, let's see, who is hospice for? So hospice care, these are always the tricky ones, and we can move to the next slide, Kimberly. So any age, we do occasionally get infants, even prenatally. Sometimes they're identified that they are not likely to live after birth very long, so we might get involved even prior to meet with the family and talk about that. And up to, obviously any age up to over 100 we've had. They have to be medically appropriate, like I mentioned already, and that 2 physicians are concurring in saying that. They have to no longer be seeking curative treatments. So when we meet with families, we're talking about philosophy with them, because they may be medically appropriate, but they may not philosophically be ready to have hospice. They may continue to want their treatments that they've been getting. All the different diagnoses, it's not just cancer, it's end-stage cardiac, end-stage lung, liver, renal, AIDS, Parkinson's, ALS, dementia. Sometimes they don't have a specific diagnosis. It might be somebody that's elderly. Maybe they don't have any, particular condition, chronic condition. They just might be aging and declining. And so we do obviously have a diagnosis for that. We call it something specific, more of like just a decline. We can't say failure to thrive anymore. So there's a specific thing that we can use. And those Medicare guidelines that I mentioned are what help us to determine specific illnesses. So the nurse, when she goes out to the home and we don't have any clear information ahead of time, because like I said, when the referral comes in, the referral people are getting the information from either the hospital setting or the doctor's office. And sometimes the referral might come from home, and maybe they haven't seen the doctor ever in years or months, and maybe the doctor isn't sure of what's going on. So we might have very limited information. So in those cases, we send a nurse and a social worker out to the home to do what we call a medical pre-assess. And that nurse, although he or she can't do a physical exam, what they gather is the changes that have been occurring. So, all right, what kind of functional changes have their family seen? Has there been weight loss? What's been going on? What's making them think hospice? And then they review that with a hospice doctor over the phone, and then they're prepared to admit if they're appropriate. And like I said before too, the hospice doctor is the doctor that determines whether they're appropriate in the diagnosis. Okay, Kimberly. So things to consider, like if you're thinking about, I don't know, like, is this person appropriate? You know, i- Things to kind of keep in your mind are, are they going to the hospital a lot? They get to the hospital and, kind of seem to do better for, few weeks, few months, and then they're right back in, or maybe they're going to the ER in between. Those are kind of red flags to think maybe there's something going on. Maybe there are other things to talk about. Do they have a lot of infections? Are they having a decline in their appetite or a significant weight loss that's unintended? Has there been a rapid decline in health, even after aggressive treatments? So, they may be getting chemo but they're not tolerating it well. And so they are declining and they're maybe no longer even a candidate for aggressive treatments. Are they having uncontrolled shortness of breath, pain, nausea, vomiting? Have you seen a decrease in functional status? So, are they not eating the same as they were 3 months ago, 6 months ago, a year ago? Are they needing more assistance with walking and ambulation? Do they need more help with, getting dressed or, subtle things like that? Are you seeing an increase in sleeping? Are they not as alert? Are they a little more confused? Are they withdrawn? And have they just decided that they want to focus on quality of life and they really don't want to go back to the hospital anymore for their treatments? And sometimes people don't know that they have an option to stay home and be able to be managed at home.
Oh, sorry, Amy, I'm trying here.
That's okay. I know it's a little
Why it's not
tricky.
going.
It's a little tricky. So we talked about, like, anybody can make a referral. So we get referrals from all sources, sometimes it's the families. Sometimes it's it might be the patient's doctor, it might be the hospital setting. So anybody can call. We're 24/7. People do call us off hours, and they do have an on-call nurse that can take that referral. And then, but primarily it's Monday through Friday, 8 to 4:30, that the referrals come into our office. And then the referral people here determine really what they're seeking on the other end. So sometimes people are just seeking information about hospice. They want to know what our services are. They may not be ready to have anybody even come out. Sometimes they, it's the hospital setting and the patient is still in the hospital, looking to have a hospital meeting with hospice to determine whether they want hospice, and we help transition that person home. So when these referrals come in, it's a process really of determining what the need is, whether they're going to be medically appropriate or whether we have to determine that yet, whether we have to talk about caregiving, whether they have a safe plan of care, which we'll talk about a little bit in a little bit. And then we have an admission team. And so a nurse and a social worker from hospice go out to the home or where the person is living and do the enrollment and get them enrolled into hospice. And then we always say, the earlier the better. Like I said in the beginning, a lot of times people think of hospice in their final hours or days when they're really close to death. And the reality is we better serve people the sooner we get in, because we can build a relationship, we can build that trust. They get families when things are going pretty okay, or people are a little, not big changes and they have some time. They get to know what we're about, they get comfortable. And so then we also recognize when things are getting closer to the end and we can better support them. That isn't always the case, of course. We do get very late referrals. I think off the top of my head, we enroll people and about 40% do die within the first 7 days. So we do have a big turnover of patients. And that's really hard. And sometimes they only meet us, the nurse once. Sometimes it's only, the admission nurse, and then the on-call nurse might go out. So, as part of my role as the educator, I'm always like, meet all new nurses and new social workers and everybody. And really every encounter matters because we might be the only face they see.
Yeah.
Yeah.
Yeah, I see that all the time, Amy,
Yeah.
because people want to, there is a thought process that hospice really is for the last week or two of life. And in
Yes.
that way, the caregiver's not supported, the family's not supported.
Right.
There's so many benefits. I mean, it doesn't have to be 6 months, but earlier. And
Right.
while we're here also, Amy,
Yep.
there's 2 questions. I wanted to, when you're talking about a referral, just mention the question that came in through an individual who registered asking about what if there is no healthcare proxy, and my understanding of that was, can somebody who can make the referral? Do I need to have a healthcare proxy from my mom or my dad or my brother or my husband in order to make that referral?
Okay. So no, you don't. Anybody can make a referral. We don't, everybody doesn't have those kind of things in place. And if they're able, like, if the person is admitted and they're able to appoint somebody and make a decision of who they might want as a healthcare proxy, we do obviously encourage that, and we can help with that process. If they're unable to make that decision, then, New York State does have the surrogate law in place that we follow to who would be the decision maker. And it just depends on if they're married and have a spouse, or otherwise it falls to the children. But yes, anybody can.
Okay.
Okay.
And one other question on the topic of eating, Patricia says, so on the subject of eating, will hospice provide an oral motor assessment if requested by the family? I'm not sure what that is.
Oh, okay. So like a swallowing eval, maybe. So
I'm not sure. Patricia
probably,
yeah.
Yeah, probably it's a swelling. We don't typically do that. We can contract with like a speech therapist at, I think it's St. Camillus, if we were to need to do that. But typically we kind of use our judgment, or we have that information like from the hospital. If they've just recently been in the hospital and had a swallow eval done, they might recommend the consistency of liquids, whether it be thickened to nectar or honey or whatnot. And so we follow that, or typically, and if they don't have that, we we talk about whether it's, can they safely swallow? We can get thicket in the home to thicken liquids for them and things like that. We just educate the family.
Okay. All right. Thanks, Amy. Forward.
Yep. So starting the conversation. So like there are a lot of myths around hospice. Many people think, that like we just talked about, that it has to be at the end of life. There's a lot of other myths that surround it. We do not, support assisted suicide. We're really about a natural, supporting a natural dying process. We're not for euthanasia. We don't hasten death in that way. People do not have to have a DNR. So that's, one of the myths too, that people think they have to be a DNR. So sometimes that surprises people. We obviously talk about that philosophically and encourage it, but they don't have to have that. So when you're, some of the things that, people, I think Kimberly said in her opening, thinking about mortality and dying is a difficult thing to think about. Doesn't come natural for everybody to think about those things. But it is important discussion. And many times we find people are thinking about them and just haven't voiced them. So I think asking people, what they want, what matters most to them, how do they want to be cared for? Where do they want to be cared for? Do they want to be home? Do they maybe they don't want to be home? Younger people, we encounter, with young children, maybe that loved one, person really doesn't want to die in their home, and they want to, maybe that's a Francis House referral. Like, we want to make sure that, try to honor that the best we can. So thinking about those kinds of things, the advanced directives is very important, and if people don't have these things established now, even if they're not at their end of their life, anybody at any stage should really ideally have those things in place. We know that's not a perfect world and that people don't, but to think about, if you suddenly couldn't make your decision for yourself, have you expressed this? So living wills, are helpful in that respect. Sometimes, we've encountered people that do at least have a living will, and maybe they no longer can speak for themselves, but that gives a framework or a reference as to what their wishes, and that helps family. Are there treatments that this person wants or doesn't want? Who do they want to be surrounded by, and where do they want to be? And again, just by doing these things, it helps the family, although they may not agree. Maybe they're all on different pages. They don't, maybe they think, mom or dad or there should do something, that they don't agree with. By being able to say this is what they want, this is what they've expressed, it does help the family to be able to turn to that. And we can, as hospice, we can help, help support the family by saying, but this is what your mom has said, or this is what your dad has said. And so I think, just openly trying to talk about those things is, the best way.
Oh, good. Amy, one other question regarding feeding. I believe they're talking about the aides feeding the family members. It says also, does hospice educate aides on feeding methods, or is that the family's responsibility?
So, well, it would be the family. I mean, we have, or if it's private, so it gets a little, it's not a clear cut answer. So for hospice, we have, primarily we have LPNs that work for us that provide personal care, and may assist with feeding. So they're LPNs, they're nurses. We have one home health aide that is employed by hospice. And so we would educate that home health aide if it's during that time that they're there. Family, it depends on who that person is being cared for. If the patient has private caregivers that the family is paying that caregiver to care for that person, it's the family who does the teaching to that caregiver, because it's considered like a contract between, like, a hired caregiver for that family. So they are the ones that actually do the education. We educate the family, but they then educate anybody they've hired to care for their loved one.
Okay.
If that makes sense. It's a little tricky, but I think that answered it.
Okay, so the LPNs can assist with feeding,
Yeah.
and maybe talking with the family about
Yes.
methods and so forth. And the health aides wouldn't necessarily be doing the feeding, right?
I mean, it would depend on what the family wants.
Okay.
Like, like the family, and it's really like when we, if somebody needs to be fed, which, many people, do, we're always educating on the safety and aspiration precautions and the benefit and the burden of what they're doing. And so, somebody may be, may not even be appropriate for them to be, getting a lot of food or fluids because maybe their body can't manage that well anymore. Or they're not tolerating it anymore. So we're having, depending on the circumstances, we're having those discussions as well.
Right.
But we do a lot of education on making sure that they can swallow safely, that they're taking the precautions needed to avoid an aspiration and things of that nature.
Good. Okay. Okay. One other question, Amy.
Yeah, that's fine.
Is the Francis House the only residence in the central New York area for terminally ill or hospice patients?
So Francis House, right. So Francis House is it's really a hospice. That people think of it as a hospice house. So they are a private home, 16 beds. They're their own entity. So they're not like connected under us, but everybody over there has hospice care. So we work very closely with Francis House when they do their own screenings for their home. And when I say that, that means like if somebody's interested in Francis House, we encourage families to call Francis House directly. That's how Francis House wants it. And then they talk about what Francis House does. And then they send somebody out to the home to do what they call a screening. And they make sure that, you know, they've had a conversation with hospice, that they are philosophically on board with hospice. And then they get on their referral list. So every week they're taking either patients from hospital settings that are enrolling in hospice over there, or they transfer sometimes patients that are already hospice patients and now can no longer be at home for whatever reason. Then they take a transfer to their home. But they are limited because there's only 16 beds max. In Auburn, there is Matthew House, which is a 2-bed home.
Oh,
And that is connected directly. That's like run by run by volunteers. It's independent as well. But it's linked more to hospice under a hospice umbrella. So they're limited to only 2 beds. And then we do serve people in group homes. And then we serve people, nursing homes that we contract with. We can also provide services in those settings.
okay, great.
Okay.
I'm always hoping that more inpatient hospice facilities would be open. I know the cost is tremendous, but
I think there's so many regulations with it, is my
Yeah.
understanding, and they don't, and there has to be a need. So like, for instance, this is what I've been told over my years here, is that the department, they don't see our area as a need to have it like within our hospitals, which doesn't seem like logical, but it's
No.
because there is a big need. But like Albany area and Buffalo, they have freestanding hospices. Yeah.
Yeah.
It would be nice if we did.
No,
Yeah.
I definitely think there's a need just based on my experience in the
Agreed.
community, but that's
Yep.
that. So,
Yep.
okay. All right, thanks.
Yeah.
Okay, here we go.
Okay. So again, this is stuff I've already touched on a little bit, that we don't, the misunderstandings or misconceptions. So I'll skip over some of that. Homebound is one. People think sometimes they have to be homebound, and that's for traditional home care services. That is a criteria for Medicare. For our services, that's not. People can come and go. They can, we even have people that are
Oops,
good and,
sorry.
you know, well enough. That's okay. That they're well enough that they can, you know, even, you
Don't
know,
where we were.
travel and things like that. Whoop.
Where were we? Where are we? Am I
Back.
going backwards? I'm
Yep, you're
sorry.
going forward. Yep.
Oh, I meant to go backward. All right, hang on. Sorry.
That's okay.
Sorry, everyone. I don't usually do this for the, here we
I
go.
know, there we are. That's okay. Yep, so you can go to the next one.
Okay.
Okay.
Well, I like one thing I liked about this is the your bullet where it says people believe that choosing hospice, they're giving up on living.
Right.
Because that's a big one, you know, with folks, but it's really you know, in my experience and probably yours, when people do get onto hospice, they really are able to live more freely. And
Yes.
yeah, it's really
And that's a good point. And I think, you know, right, they don't want to have to have hospice services, but that is our goal, is to help them, you know, try to focus on living. Even though we're about end of life, our focus really is on helping them live fully. And what do they want to still accomplish? And, you know, sometimes there's time to be able to do some things, or maybe their goals have changed. Maybe they're not able. We've had people that, you know, wanted to get to the beach one more time, and, you know, maybe they declined very quickly, but like people brought the sand to her, you know, and made like a beach. And so there's things that we can think outside the box to help them, you know, have some good memories.
Yeah, Thanks.
Yep. So our services, that we, they obviously have to be medically appropriate, philosophically on board. And then I didn't really go into depth about the caregiving yet. But one of the really big things that we have to talk about with families is who's going to care for them. Because we are a supportive service. We don't come in and provide 24-hour hands-on care. That does fall to either family or whoever they've hired to care for that person. And sometimes, those are things that they have to still like think about or navigate. And we can't enroll because maybe they don't have a safe plan yet. So then we come back once they have that in place, or we get them thinking about, who would be able to care for you. Sometimes we do have people that are still living alone. They're well enough to still live alone. But when we meet with them and their family, we talk about what's your plan going to be? What have you thought about? And make sure like they are agreeable to certain things, that they're willing to go somewhere if they need to, or they're willing to have somebody come into their home to care for them, or maybe the daughter is going to take an FMLA. So we talk about those things. And if we're hearing that maybe they don't have the solid plan in place, but they're thinking about it and they're willing, we can go ahead and enroll them. Sometimes we're not able to enroll if they truly don't have a safe plan. We might be making an urgent referral to Francis House in those cases, and trying to get them there as soon as we can. So there's a lot that goes into that, and a lot of discussion around the caregiving. It's a big stressor for families. We recognize that, but we are not able to go in and provide 24-hour care to all of our patients. We are 24/7, so that is the support that we give families. We are available 24 hours a day. So off hours, we have an answering service and a triage nurse and on-call nurses that can go out. We're on call. Our doctors are on call 24/7 for symptom management. Social workers, chaplains, all of us are on call 24/7. And so we have that availability. We serve all of Onondaga County, all of Cayuga County, parts of Madison, and parts of Oswego. So we serve a very large territory. Just to give you some reference, so last month we had 211 referrals and an average daily census of about 132. We have peaked at 170 in the 170s. We'd like to get back up to the 150s. Right now we're staying in the 130 range. And our average length of stay is 52 days. I mentioned a vast majority are only with us 7 days or less, but our average length of stay is 52 days. And that's just our fiscal year is a May to May. So this past May, it showed that last year we served 1,381 patients. Okay.
Hang on, it's me again.
Yep.
I just wanted to clarify that when you say your nursing staff and so forth, you're 24/7, meaning that the family or the caregiver or the individual who's on hospice can call at any time and
Correct.
reach a nurse okay.
And that's what we encourage. So when they enroll, we give them they get assigned a team. They get assigned a nurse that sees them regularly. Their nurse that works Monday through Friday will see them at least on a weekly basis, but more often if needed during the week. They get assigned a social worker, a chaplain as part of the team. And then that off hours is that same number. So it's the same number that they 634-1100. And they may just call because they just, maybe they just have a question about something, or maybe they have the patient has a symptom issue going on. Maybe they just, need support. So there's a lot of things that the nurse is going to be able to manage over the phone. But if they're calling and they're calling again, we're going to send a nurse. We're going to send somebody out there and see what's going on. And many times it is really just validating what they're doing is the right thing, that, supporting them, that what they're doing is, recognizing this is hard, but that they're doing, the right thing. And, or it might be just re-educating them on the medications and things like that, that they have available to them, and doing those kinds of things. We do attend all deaths. So when somebody passes and a nurse does go out to the home, but we also could offer social work or chaplain support at that time too.
And speaking of the team, Amy, when is a hospice volunteer visitor made available, or how does that happen? Because
Yep.
that's a huge part of, it's a huge and wonderful part of hospice is the volunteer staff.
Absolutely. So when they are enrolled with hospice, part of what they ask is they offer a volunteer. They're referred to as family caregivers. Our family caregivers go through a 6 or 7 week training for hospice. They follow and do all the things that paid staff do. We actually have to have a certain amount of volunteer hours. That's because of the nature of hospice, the grassroots nature of it was originally volunteer. So part of the benefit is that, or regulations rather, is that we have to continue to have volunteer services. So we offer it to families, and some of the things that they can do, they might be a companion in the home. They might be able to go out and be a friendly visit to the patient, and it gives the family or the caregiver time to maybe run an errand or just go for a walk or step away and just know that somebody is with somebody. They can be, even if the person isn't able to engage in conversation, they can be respite, so they could be a presence in the home. They can run errands for the family. Sometimes they, we have some, they have skills, so they might, hairdresser, or some have legal skills, so they might be able to go out and like be a notary for a family if they need that. So there's a variety of services and skills that they have. And we have volunteer coordinators that work here at hospice. And so they take all the requests that come in from admission, or maybe not at admission, but it might be down the road that they decide that, maybe a volunteer would be good, or maybe the nurse recognizes, or the social worker recognizes that a volunteer would be helpful in this home. So they would put a referral in. And then what those coordinators do is reach out to their caregivers to say who would be able to do this. So they're very valuable to us. And they also do a lot of them that maybe aren't able to go into homes anymore. They do a lot of crocheting. So we have like a ton of different things that we can bring to families, whether it be blankets or, special feeding bibs. And we have crocheted like little stuffed animals that, are beneficial to some of our patients, or if they have young children, things like that. So they're very, very valuable to us.
Excellent. Thank you.
So a few more services that we have. So the nursing, of course, and the nurse, like I said, goes out and does a physical assessment weekly, but they're really there for that symptom management. They coordinate everything. They're making sure, reporting to the patient's attending physician, talking to our doctors. The social worker is very, very valuable. Sometimes the families have not even had, any plans for funeral arrangements. So they're there to help with, assist with that, final arrangements. They might be helping with any legal issues or FMLA papers. They can help navigate those types of things. They also are there, obviously, as an additional support to patients and families. Sometimes the nurse and social worker, particular cases, they'll do joint visits together to kind of support each other as well into the homes. Spiritual care, we have chaplains that work for us, and they are non-denominational. They do just a variety of things. Sometimes they're just a nice presence or an additional, person to talk to. Sometimes they are more not really religious, but they might be able to do that, like be a liaison to the person's pastor, or if they're asking for a priest, or they want a particular service done. And some of them do the funerals for them. If they don't have anybody to do that, they will do that. Physician services. So we're very fortunate here to have full-time physicians that are here every day for us. So we have one full-time medical director, and then we have other part-time. And so every day we have at least 2 physicians available to us right here in the office, and then they rotate to be on call for us. The home health aide LPN services we talked a little about earlier, and our LPNs are very valuable to us because not only are they nurses, they can do the personal care, but they also, being a nurse, they can do a task. So if there's somebody has a wound or a drain or things of that nature, or they need education on something, they can provide that while they're there as well. The volunteers we talked about. Part of hospice services too is that we need to be paying for medications that they're on that are related to their diagnosis that they're coming in for, and any related diagnoses that are impacting that. So what I mean by that is, like, if somebody was admitted with lung cancer, but they have an underlying COPD that's impacting that lung cancer, we would be looking at their COPD meds as well. And then the nurse sorts all of that out, and any medications that we are paying for, we get through an out-of-state pharmacy that's delivered by FedEx to their door. We get any durable medical equipment. So we contract with a vendor, Nuns, and they provide the bed, commode, walker, wheelchair, things of that nature, oxygen if they qualify for that. Medical supplies, we have all the medical supplies, like chucks, briefs, if they have wounds, drains, all of those things, we have them here and we replenish those. And then treatments and therapies that are deemed necessary. So what I mean by that is, once somebody enrolls with hospice, we become the overseers of their care, because we're accessing, which I'll get into the payment in another slide, but we're accessing the Medicare benefit. So therefore, it's really saying that hospice is now your overseers of care. So you're choosing to no longer, go for like CT scans and go for lab work and without talking to hospice, because we would be responsible for those payments. So we're focusing on, and comfort care. So many of those things aren't necessary. And that's what we talk to patients and families about, that those tests no longer are going to benefit you, because how you're telling us how you look, or how you're feeling, how you slept, how you're eating, how your pain is, those are going to tell us much more in how to care for you than lab work and CT scans and things like that. So it is a choice, and it is something they have to think about when they enroll. But sometimes it is necessary. For instance, if somebody has a fall, we may suspect they broke a bone. That's part of comfort care to, we would want to get that x-rayed, and potentially if it was appropriate, maybe they even, would want to have surgery. So we don't necessarily just disenroll. We would, families would call us if there's a fall. We might send them to the hospital to get looked at. Now, if they are really, depending on what the family and patient wants, sometimes they don't want that. Sometimes they still want to just be managed at home and have their pain managed with what's going on at home. And we really support whatever the patient and family want in those circumstances. Sometimes we do send people to, maybe get a drain placed because it's appropriate to get fluid removed from their lung or their belly, because it's going to provide comfort. So there are sometimes things that we do, but we're always looking at it from the lens of comfort care, and whether doing what we do, is that going to provide more comfort? Is that going to help, or is it not necessary, kind of thing? Okay.
Okay. Hang on.
Yep.
I'm working on it. There we go. I think.
Okay. So we talked about where our services are, and the vast majority are where, well, obviously it's wherever they consider home. So the vast majority are either in their home or a family member's home, or something of that nature. We talked about the live alone. So initially, sometimes they can live alone, but we talk about that plan as their condition changes. Francis House, Matthew House, group homes, and then the contracted nursing facilities. Now, just to note, with nursing facilities, it is a little different type of care in those homes. We are considered really an added layer of support in the nursing homes. They still get all the care provided to them at the facility. The doctor at the facility writes the orders. We don't write orders. We don't provide verbal orders to them. They're regulated very differently, of course. So they do what they do, but we add that added layer for the family, the patient, and we're like another oversight to manage any symptoms. Currently, we don't have any patients in the nursing homes. And so we hope next year to get back to being able to provide care and supports.
I hope so.
Yeah.
Makes a difference. When I was working with hospice and in nursing homes, it makes a tremendous difference to the family, especially.
It definitely does. Yep, for
Okay.
sure. So how are we paid for? So first off, nobody's ever denied in the inability to pay. If they have insurance, we run all of that prior to talking with the family so that we can fully inform them. So if they don't qualify, the vast majority are Medicare, of course. And so if they qualify for Medicare, like there is that special hospice benefit within it, and that becomes their primary payer for us. Medicare pays us daily per diem rate, and we accept whatever Medicare gives us. And it covers all of the services that I previously talked about with the visits, the medications, the equipment, and supplies and things of that nature. Medicaid also provides us with a daily rate. So somebody may have Medicare and Medicaid, but Medicare would become their primary over the Medicaid. Private insurances, most insurances have a hospice benefit within it. They all can vary. So our finance people here run that insurance to be able to, so that the social worker can explain to the patients and families what their insurance is going to pay. So sometimes they pay 100%, just like Medicare would. Sometimes there might be a copay or an out-of-pocket deductible they have to meet before they'll pay. In those cases, there is, we still, they have to fill out a form of what they would pay us. But again, we never want it to be the overriding burden. So if they don't have the ability, let's say they have a $15 a day copay, and that would be a burden for them. If they could put $1, they could put $0, and we're not going to come and bill them after somebody dies. We're not going to come looking for that money, if they can't pay for it. We depend highly on the foundation center. So our donations and fundraising comes through our foundation. They help bridge the gap of the cost of care to keep us afloat. So there, just so you're informed, so Medicare, they give us 4 levels of care that they'll pay for hospice. That's what this means. Routine home care is which is what I've been talking about all night, which is the care provided in a home setting, or like Francis House or a nursing home. And that's the majority of what our patients are getting. Continuous home care is another reason. This would be a very rare situation. So this might be, if I say crisis situation, so we might recognize a family that maybe the family has been up, not getting any sleep 24/7. The situation is, the patient is not sleeping, up all night, and really, it's very difficult. This family's exhausted, basically. So we would offer to look for some overnight nursing for them. We can't guarantee it because, quite frankly, there is not a lot of agencies out there anymore that are providing this, but we would actively look for that. And we might even offer it to our LPNs for, to be able to do that as well for pay. So we would look for that and it wouldn't be to be ongoing. It would be with the intent of giving them some respite for a night or two. It could even be a home health aide level of care, depending on what this family needs. So that's what that means. And that's paid, that's a different rate under Medicare and a different situation. Our next bullet point, the general inpatient care, is really for patients that maybe their symptoms are not being well managed at home. And we're saying they need to go to the hospital, or suggesting they go to the hospital to get that symptom managed under control. And then we look to either get them back home or wherever they need to go. Now, I say it's not for caregiving, and many times that is the situation in homes where they are exhausted and they may have called 911, they may have sent them to the hospital. Medicare will not pay for that, and we talk to the family about that being a cost to them. But if we're sending somebody to the hospital, they continue to be a hospice patient in the hospital setting. We see them every day at the hospital, and we work with the facility that they're at, and we get that symptom managed, and then we get them back home. So it's meant to be short term. And then respite is also a payment under Medicare, and this is intended for in a nursing home or a skilled nursing facility. They will pay for 5 days of respite care for the patient to stay. So this might be a situation where maybe the family is going out of town for a wedding, or maybe they just need a break, from caregiving. So the sooner we know those situations, we can actively start working on it. There's a process. There's we have to contact the facilities. They have to make sure there's a bed available for them. We have to make sure that they will, accept that patient. And there's a contract that we would have with that facility. So that's not guaranteed, but we would actively look. So obviously the sooner the better in those situations. And then we would look to transfer that patient there short term. And they can have that. To my understanding, there's not a limit under Medicare to the amount of times they can have that. So occasionally we have that as well for our patients. We can go to the next slide. So grief services are also a very important part of our services. When somebody is enrolled, we really say that grief services start upon enrollment. That family is grieving and anticipating the loss of their loved one. So we are, the social workers involved, preparing, nurses preparing. And we let them know at the time that we enroll that after their loved one dies, that they will be followed by the grief center up to 13 months free. They can access services, and we do it 13 months, so it gets them through that first calendar year and beyond. During that time, sometimes people, everybody is different, obviously. So some people, things were they don't need grief services. They maybe don't think they do in the beginning, but maybe 6 months down the road around the anniversary, they do. So just for them to know, they get mailings sent out to them to remind them that they have those services. Some of the services that we provide, we have support groups. Some, pertain to spouse losses or partner losses. Some are for children, things of that nature. If they're routine grief, so meaning there really wasn't anything identified that would say that this family is complicated grief, maybe there's just normal, if you will, grieving, then we would have a volunteer who's specially trained in making these calls. They would make the initial call, and then the social worker who's been on the team would follow them up with anything that volunteer identified. If there was to be more. Complicated grief families are supported up to 3 months for monthly phone calls. And if anything is identified that really is beyond what they're able to provide, they would refer them to other resources in the area. We do have a special time in August that we do Camp Healing Hearts, and that's a day camp for grieving children. We have bereavement library resources so that if people call, our grief counselor can send resources to them or refer them to places. we do a couple of different things. Twice a year, we do a service of remembrance. And people that have lost somebody in the previous 6 months get an invitation. With COVID, we've done these virtually. They are on our main website, and it's a nice, they have an opportunity to send a picture and make a, send in some memory of their loved one that's passed. So they're part of that service as well. So that's a nice thing that they do.
It's very nice.
Yep. And then we do have Pathway newsletter, biannual publication with articles that is on our main website. People have access to that. The hospice social work grief care is what I mentioned. That's what I meant when the social worker follows up with them. It's been the team social worker so that they already know the family. And then we send out mailings. Okay.
Oh, hang on.
And then that's our website. Now our website has a lot of detailed information on it. I would encourage you to look at it. It does say many of the things that I've talked about tonight. It talks about advanced planning. It talks about how to talk to family, conversation starters. Talks about the referral process. So a lot of this information is really right on that website. So I would encourage you to note that. And then our number is 315-634-1100, and that is the same number 24/7. If you ever had any questions or wanted clarifications, I would encourage you to call that number too.
Okay. Well, Amy, thank you so very much. By the way, I did have one other question from a participant about, she asked what the, oh gosh, I'm trying to, hang on a second. Oh, the medical director, if you know who the medical director is at current time.
Oh yes, Dr. Julie King is our current medical director. It was Dr. Setla for, and she just, we've had a 3-year transition. So Dr. King came on board 3 years ago and worked under Dr. Setla, who's been our medical director for 20 years. Yep.
Okay.
And she's still here, but she's part-time now.
All right. I think there was one other question. Does hospice provide palliative care? And if not, who would provide that? It's a good question.
So
I think she means non-hospice palliative care.
Right, and it is a good question. We don't provide separate palliative care services. One of the things, you know, is there isn't a payment source for just palliative care. Medicare won't just pay for palliative care. That's one of the obstacles. But we work closely with the palliative care teams in all the area hospitals. We have a couple of part-time physicians that do work palliative care, like either in oncology or in the hospital setting, that also work here. So we work closely with them to be able to identify, but yeah, we don't provide at this time separate services.
Yeah, I worked when I worked with the Hospice and Palliative Care Association. We worked really hard to try and get a palliative care benefit.
Yes,
and some insurance companies actually do have them.
Some do.
Yeah, outside of Medicare. So most insurances will obviously will still cover hospice, but check with your insurance company as well if you're non-Medicare, if you're not on a Medicare plan.
Right.
And I think that mission will continue to try and get palliative care benefit.
I think so.
I mean,
too.
there's some, like visiting nurses, can provide it. So there are some teams,
Right.
in the community that can. So, but talk with hospice about that. I think that would be, a good place to start.
And I would say if people are just not even sometimes people aren't sure if they qualify and they hesitate to call, or to have their, somebody seen, they think they have to really know. We sometimes just calling and having us come out and being able to give that information to you is so valuable. And then at least even if you don't qualify or you're not quite ready, they have what they need to know to make a decision going forward. They know what we're about. So that I would just encourage you to keep that in mind for anybody that you're, encounter or working with.
Right. Yeah, having a family meeting doesn't mean you
Right.
need to be a hospice election necessarily follow. So it's a
Right.
really good point. Okay. All right. Well, this has been wonderful. Are there any additional questions anyone has? I'm glad you were so interactive, because I think asking questions really helps to, bring out, so much more information than you think of.
Yes.
Yeah, no questions?
No questions.
Okay. Well, this was wonderful. Amy, I can't thank you enough at the end of your
Well,
long day. I know you're at the
Oh,
office.
thank you. No,
Um,
it's my pleasure, really. Thank you so much for having me.
Go home. Yep. And
Yep.
enjoy it. And thank you everyone who attended. I'll be sending out a follow-up email probably tomorrow, and we'll send out that PowerPoint for you, so you'll have that for your reference. And it usually takes me a few days to edit videos, but we'll provide that for you as well. So thank you everybody who came. Thank you, Amy, so
Thank
very
you.
much.
Okay.
And take care, everyone. I hope you all have a great Thanksgiving, because I'm sure I won't see you before then. Okay, bye.